Yeah, that's a great question. What we understand how colon cancers progress or develop is through the adenoma carcinoma sequence. And it takes a series of changes for the normal lining of the colon to turn into adenomas. And then a series of mutations and dysplastic events have to accrue for it to turn into cancer. This process is slow, we think somewhere between 8 and 20 years. But it is the predominant pathway that most cancers develop through. And there are studies showing that if we remove polyps, these adenomatous polyps in particular, or the advanced adenomas, which are have acquired some mutations and are more advanced along the path, we actually do prevent cancer from developing in the long run. And we also reduce the risk of dying from cancer. So our study was the first one to report that non-advanced adenomas are also associated with an increase in incidence of colorectal cancer, even though the adenomas are removed over many years of follow-up. And the reasons for that are twofold. Either patient characteristics, the patients are at increased risk of developing adenomas and subsequently developing more adenomas that could progress. So it could be patient factors, or it could be colonoscopy and endoscopy factors. The polyp wasn't removed completely, and any tissue that's left behind has a much higher chance of progressing rapidly and turning into cancer. And that's where the endoscopist doing the procedure is very important, that it's a high-quality endoscopist that is able to detect and remove the adenomas completely. So removal of adenomas from studies has demonstrated a reduction in developing colorectal cancer of anywhere between 50 to 85%. So over a long term, removing these lesions is extremely effective strategy for preventing colon cancer. The study demonstrates that we can actually risk stratify individuals based on the findings at colonoscopy. So individuals that have no adenomas or advanced adenomas on their colonoscopy are considered, at pretty low risk for developing cancer in the subsequent years. And hence, we don't need to screen them as often. So for now, it's 10 years is the interval. For individuals with adenomas, we should be bringing them back. Currently, the recommendations are 7 to 10 years. And in particular, individuals with advanced adenomas, just kind of earmark them for being at increased risk of both cancer incidence as well as death from colon cancer. So those are really the individuals we should focus on, making sure that we do colonoscopies every 3 years, making sure that they don't miss their appointments. If we have navigation or reminder services, then we should really target it at that high risk population, more so than everybody in general, because those people definitely are at increased risk. And their colonoscopy just needs to be high quality, done by an endoscopist that can detect all the lesions and confidently remove them completely. So this is a very important area of technology and growth that we are all looking closely at. We would love to have certain biomarkers, be it stool-based, blood-based, or maybe just a compilation of different factors, such as the patient's age, their risk factors, put together into a risk score, to be able to, again, risk stratify individuals as individuals that are perhaps at increased risk that we should monitor closely, maybe even closer than 3 years, and make sure that they get their follow-up versus individuals that could have a longer follow-up. So we are looking for those biomarkers and tests. They could also indicate when an individual needs their next colonoscopy. So supposing we had a wonderful marker that suggests that there might be prevalent advanced adenomas, then that would be the time to get them a colonoscopy, and perhaps we could repeat it for individuals that are negative for the test, and wait for the colonoscopy until a test indicates that they should undergo the next colonoscopy. Because we don't understand, exactly when to bring people back, and we do tend to overshoot or undershoot. So, a biomarker or some kind of a risk stratification tool would really help our efforts. We are looking at other long-term follow-up studies that have been done in the US, and there are many in Europe and other parts of the world, to see if we can either pool their data with ours and see if the results either change or get stronger. And then also we want to take a deeper dive into this issue of completely removing polyps, and also quality of the colonoscopy that was done, to ensure that we could tease out, for instance, risk based on who did the colonoscopy, and do we think that they were likely to have either missed something important or have incompletely resected something and left something behind.